Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Lateef Khan, working as a consultant orthopedic and spine surgeon in Gurkita's Teaching Hospital. I will be discussing the minimally invasive spine surgery for osteoporotic fracture. In US, more than 50 million people have osteoporosis. The major source of morbidity and community healthcare cost from osteoporosis are related to fractures. By the age of 50, the remaining lifetime risk is 1 in 2 for women and 1 in 5 for men. The most common presentation of osteoporotic fracture is asymptomatic incidental finding on the x-rays, but patient sometimes present with pain and fracture on radiographs, most commonly from T8 to L4. The physical examination is mostly normal, but local kyphosis and midline tenderness is also there. Common chronic collapse present with kyphosis and loss of height. The common radiological investigation for these fractures are plain X-rays, most common in the lateral view, sagittal and transverse view of CT scan, and MRI to look for canal compromise, comminutions and integrity of the end plate. The goal of treatment in these patients is early mobilization and acquisition of a panelless, balanced, stable vertebral column with maximum spinal mobility and optimal neurological function. The most common treatment options for these fractures are conservative, operative, and minimal invasive spine surgery. The conservative treatment basically consists of bed rest, bracing, and the use of analgesia. Patients are commonly assessed for osteoporosis and its underlying cause and treated accordingly. Among elderly patients, inactivity and immobility lead to serious complications like pneumonia, decubitus ulcer, venous thromboembolism, and ultimately death. In addition, analgesics and braces are poorly tolerated by the patients. The open surgical options are indicated in patient with neurological deficits, severe spinal instability, kyphotic deformity, more than 30-degree canal compromise, and vertebral height loss more than 50%. Open surgical options are posterior stabilization with rods and screw, with and without decompression. It can be short segment and long segment. Anterior decompression and stabilization can also be done. However, surgical possibilities are limited because of decreased bone quality. The development of minimally invasive spine surgery during the first decade of this century has provided better treatment alternatives as compared to the open surgery. Because compared to younger population, high rate of complication is associated with open surgical options. Minimally invasive surgery for osteoporotic fracture are percutaneous vertebroplasty and kyphoplasty. Gilbert and Edmond first performed vertebroplasty in 1984 by injecting cement into C2 vertebra that was destroyed by hemangioma. After that, this procedure was frequently and safely performed in treating osteoporotic fracture and burst fracture of thoracolumbar region. Percutaneous vertebroplasty is performed in prone position on radiolucent table under image intensifier in local anesthesia with moderate amount of sedation. The tray for vertebroplasty consists of a bowl for mixing the cement, mallet, trocar, and cannula, various size of syringes, artery forceps, and cement. The most common cement used in vertebroplasty is polymethyl methacrylate. First, the fracture vertebra is identified, then the important landmark like transverse process, pedicle and spinous process and end plates are located. Then cannula is inserted under image guidance in AP and lateral view. The main aim is to advance the cannula up to the anterior two-thirds of the vertebral body. The cement is mixed until it achieves a consistency of toothpaste. High density, high viscosity cement is commonly used to prevent the leakage into canal or disc space or adjacent tissue. The major symptomatic procedural complication from vertebroplasty is adjacent segment fractures, leakage of cement, most commonly to disc space, canal, and paravertebral tissue, pulmonary embolism, a local infection and local hematoma formation has also been described. Balloon kyphoplasty is performed similarly as vertebroplasty. The main difference is the creation of a cavity by inflating a balloon and filling that cavity with bone cement. Both treatment reduce pain, disability, and improve alignment. There are some advantages of kyphoplasty versus vertebroplasty in the case of adjacent segment fractures and extravasation of cement, which are less in kyphoplasty as compared to vertebroplasty. And restoration of vertebral height and sagittal balance is also good in kyphoplasty as compared to vertebroplasty. Thank you.